So having to follow on from David is always a challenge, so hopefully I can have a bit of a go at that. We're going to change focus now, so we're going to be a bit more specific in looking at the types of cognitive and behaviour changes that can occur. And I've just really used the term atypical Parkinsonian syndromes quite loosely, just as a term to group MSA, PSP and CBD. Okay, so really the plan is, first of all, what do we mean by thinking and memory or cognition, looking at some of the common cognitive and behaviour changes and looking at how we can recognise those changes, because essentially really what the take-home point of this presentation is that the more we know about the types of cognitive and behaviour changes that can occur, the more able we are to recognise them as health professionals and provide appropriate support for patients and caregivers and also other professionals in the community. Okay, so what do we mean by thinking and memory? So when considered together, we're referring to thinking and memory as cognition, and there's a number of subdomains, and that includes attention and concentration, the way we understand and use language, the way we can assemble things together in our mind and judge distances, the way we can learn and remember new information and apply that to things that we have learnt in the past, and really our constant planning, carrying out and checking actions. And what I mean by this is everything that we do, for instance, when we're reverse parking a car, which is something that I'm not particularly great at, I'm continually planning my attack. Will I fit in the spot? How am I going? Am I going to hit the curb? And do I need to recheck my plan of action? So do I need to move out again and think about how I can go in and park my car again? So we're continually using a number of these thought processes in everything that we do. And of course, reasoning and solving problems is, you know, a really, really important issue, particularly in decision making. I guess one of the things to really focus on is that cognitive changes are not always recognised. And it may be because in the initial stages of the disorders that we're going to be talking about, they're not really obvious. So someone with a fantastic vocabulary may not be able to find the right word in conversation, but may be able to access a similar word and use that one instead. So you might not notice that they're having a word finding problem per se. And I guess the other thing is that it's only more recently that cognitive and behaviour changes have been recognised as, you know, significant factors in these syndromes. So in MSA, PSP and CBD, they were all considered primarily motor syndromes in the past, with higher or high-level cognitive functioning thought to remain relatively intact. In fact, in the first CBD diagnostic criteria, which we have heard from David unfortunately remains poor to this day, early dementia or cognitive change was actually an exclusion criteria in the early diagnoses. So I think we're recognising over time that there is cognitive and behavioural involvement. And in the next couple of slides, I'm going to justify, and I hope you'll agree with me, why people are entitled to have these difficulties. Some of the other issues are that patients and families are often more focused on more of the obvious difficulties and obvious changes that are happening. So when there's changes in mobility, people are falling over at home, there's safety issues, people are having trouble with their swallowing or feeding, that can often be the main focus, as it should be. But unfortunately, some of those underlying reasons, if they're related to changes in cognition, might not be picked up as early as they could be. And obviously, when there's swallowing or communication difficulties or speech difficulties, it's more acceptable for someone not to participate as much in social activities or converse as much as they would have, because people around them may say, well, it's because it's harder for them to talk or it's harder for them to engage, whereas in fact it may actually be due to some cognitive dysfunction. So it's just some things to keep in mind. So the other things we need to consider are that cognitive changes can emerge at any time in the disorder or the disease process. They may be early disease-related changes. In fact, we know that, for instance, in PSP or CBD, we can have some really early cognitive involvement. It happens rarely, but in PSP and CBD, we can have predominant cognitive language variants occurring first, which I'll mention a bit more, which I'll mention later. but we can have early cognitive involvement, and that's what we need to keep in mind. Of course, our difficulties, having cognitive difficulties, even if you're at work and you're just noticing that you're not as efficient or you're not as slow and things at work are becoming harder and your boss may be saying, hold on, you know, you're really not up to scratch at the moment, or things change at work, you move from a single office to an open plan office, and you've got difficulties with attention and concentration, well, they're going to be exposed, you know, in a change of environment. And therefore, you know, these things can lead to stress and misunderstanding for the person, their colleagues, family members. And so if we can have an idea of what could be going on for the person and help recognise these difficulties early, we're going to be better able to support people. Okay. And so I guess just it's wanting to really get through to everybody that, you know, nobody's the same in their presentation, so things are going to be different. And what we're going to be really working towards is looking at some of the general similarities, the typical presentations and the common approaches that we can use. And of course, particularly with these syndromes that we're talking about today, is they're rare. So it's really hard to develop really good clinical experience in diseases like this that we're not going to see very often. So we're going to have, so some things are beyond our scope, and what we do is we go to the literature, we ask the relevant associations, and we you know, collaborate with our colleagues to really get a good understanding and a good picture of what we're seeing in the patient that's presenting to us. And of course, there's always going to be outliers, and that's what we've got to remember as well. So we're going to talk a little bit about why I think it's very reasonable that people have cognitive and behaviour changes in PSP, MSA and CBD. So here we've got a picture of the basal ganglia, which David mentioned. In all three of these disorders, the basal ganglia, the structures of the basal ganglia or projections to, are affected. Okay, so the basal ganglia were thought to be only related and only involved in voluntary motor movement or in motor movements. But we now know that there is a number of circuits, and in fact the projections from the basal ganglia, so the basal ganglia receive projections from everywhere in the cortex, so from the entire cortex. Only one circuit, and there's many that have been identified, is specific to motor programs. So look, it makes sense that if these structures are being impacted, that there can be behaviour and cognitive difficulties, because the basal ganglia are involved in automatic decision making, learning and habit formation, and also selection of relevant information and appropriate behaviour and motor plans as well. So I guess, you know, when I was thinking about the prevalence or what types of cognitive and behaviour changes that we would see, it made sense to me that people were, you know, entitled to have some difficulties in these areas.